My name is Jim Cox, and today we're going to cover the use of a technique called flexion distraction. You may also know it as the name decompression distraction technique. I've developed this since 1964, named it flexion distraction in about 1966, and you're going to see the culmination of all of that work in this video, which will show you the use of the instrument, what it can do for you and for your patient load, and how you can add it into your practice. This textbook, called Low Back Pain Mechanism, Diagnosis, and Treatment, 7th edition, published by Lippincott, Williams, and Wilkins, shall serve as your guide. It will cover in even more detail the treatment of specific conditions of the entire spine, cervical, thoracic, lumbar, sacroiliac. But I'm going to take this book and put it into visualization for you at this time. I'd like to begin with the basic movements of the instrument, how to make it work for you and to make your work easier. Let's begin with the tiller bar. When you bring this tiller bar up, you have total control of the caudal section of the instrument. When you use this, this will be up and down. There's also a foot pedal here that will lower or raise the instrument for you. Above that on the tiller bar is the automated tension, the power balance of the caudal section, so that when you set the tension on the caudal section, as I'll show you, this instrument should move at just a touch of your finger, regardless of whether the patient weighs 500 pounds or 75 pounds. You will set the instrument so that it does all of the work at bringing the patient back to detente. And all that you and I have to do is control the contact and the proper force applied to the segment of the spine we are treating. And we'll be covering that in great detail. The tension here, if I increase the tension, you'll see that the tiller bar will bring the table up into greater tension. If I drop it, it will lower the tension. So whatever the size of the patient, and incidentally in a day of practice, you'll hardly ever have to touch that, because it's not that much difference between the average patients that we treat having to set the tension. But if you get a really big person, that's when you really appreciate the tiller bar tension setting. This is the knob. It's made to ergonomically accommodate the doctor hand, so that during treatment it takes pressure off of the wrist. And you know, as you and I age, and you know I'm a little older now, it means that you have to learn to work smarter, not harder. So we built ergonomics into the instrument. When you contact here, there's the least pressure on your own carpal tunnel. Your median nerve doesn't suffer. Neither does the ulnar nerve and the Guylian canal. So little things like that we've thought about in creating the instrument for you and for me to use in daily practice. Just behind this tiller bar is a button that you can contact with your middle finger to apply long Y-axis decompression. As we go through today, you'll see how easily this is to use. Incidentally, the instrument will move into caudal distraction up to almost 14 inches, so that no matter how tall the patient is, you and I can accommodate. When we begin to look at the movements of the instrument, allow me to show you the locks. On the lower end of the caudal section is the flexion extension lock here. When you release that, we can apply flexion and extension of the human spine. It's just that easy with fingertip control with proper power balance of the caudal section. This lever, lateral flexion. Again, just that easy to be done with fingertip pressure. Then when we apply lateral flexion, we can also apply lateral flexion and flexion in a movement called circumduction. Here I'm applying with the long Y-axis, using the instrument with lateral flexion to circumduct. You can also bring the patient into long y-axis, lock it under decompression, and apply lateral flexion or circumduction under long y-axis decompression, especially useful for any condition introduced spinal stenosis to the spine you were treating, because we want to increase the disc space, increase foraminal area, drop intradiscal pressures before we place faucets into the other physiological ranges of motion. You totally will run the instrument from this caudal section. When you apply long y-axis, you can do it from the tiller bar here, or as you notice, you can do it by an electrical switch here. When you press this electric switch, note that the instrument will move into long y-axis, and you'll see how we use that in clinical practice. Two safety features which are vital to you and to me as clinicians and treaters of human beings. One of them is the safety features that if anyone were to crawl underneath this instrument, and you know that there have been some fatalities from children pressing on the instrument controls, the table coming down and crushing them. Here's a safety feature which I think is absolutely essential on these instruments. You'll note that if we are bringing the table up, and if someone were underneath it and the table is moving downward, there's a pressure strip here that not only when it's contacted will it stop, it will raise the table so that if someone gets under that, it will stop, come up to release the pressure. Another feature that I'd like to share with you is that while we are using unattended long y-axis distraction, we said it, we're using unattended long y-axis distraction, and while the patient is under that, if they should feel any discomfort at all, there's a stop, a kill switch under the right armrest, a little red button that they just press, and it will stop the instrument. Okay? And we tell the patient about that whenever we start them on unattended long y-axis distraction. When you do use that, you will have to stop long y-axis here, turn the power off, turn it on again, and then you can use the unattended long y-axis again. When you want to stop unattended long y-axis, all you do is press the automated button. It will move back to neutral, to detente, and stop. Okay? So those are the basic uses of the caudal section of the instrument. We will also be talking about thoracic drops for treating sacroiliac joints. So there are thoracic drops, and I'll show you the use of them as we proceed. One last thing. On the ankle bracket, in order to apply distraction, we can use the tiller bar. All you have to do is press this lever, it releases it to decrease or increase the depth of caudal distraction. When we are ready to have the patient lie on the instrument, always note the tension on the caudal section. I have it quite reduced. Always increase that tension, kind of thinking about the size of the patient, so that before they even lie down, you know that when you release the caudal section, that it's going to be ready to resist the weight of their lower extremities. So let's have the patient lie on the instrument, Chris, if you would. You'll come over. We have all the locks are locked. Patient will lie down, and note something about patients when they lie on this instrument. They almost always will lie right where you anatomically want them to be. That is, the anterior iliac spine will be 1 to 2 inches ahead on the thoracic piece, so that the lumbar spine we are treating is right here under good thenar or thumb index contact to treat the specific motion segment that we are going to be addressing. So make sure the patient placement is proper. Always make sure that the caudal section on the end here, that the ankle bracket comfortably rests under the ankle mortise. Make sure that the cervical headpiece is a good distance. Some people like it wider, some need it closer so that they can breathe properly. So we have good patient placement on the instrument. The next thing that we will cover will be tolerance testing. And this is a most important part of Cox technique because it's where we determine the level of treatment that we start with on our patient. Some patients will tolerate more ability to tolerate flexion distraction and decompression than others. So when we do tolerance testing with the patient in place, we have the table set at a flexed angle that meets the patient's comfort. Now typically that's going to be just a slight flexion as you see here. Sometimes you may want to set that at a differing level of flexion in order to accommodate the patient's comfort. Some patients who come in an antalgic list, a sciatic scoliosis, we may want to set the lateral flexion to match their antalgic list. And we may apply decompression and flexion distraction in that postural state that releases their pain to allow them to accommodate this technique. Okay? So with the patient in place, we begin with what we call tolerance testing. And the first is just central tolerance testing. We will contact the spinous process of the vertebrae at the levels we are going to be treating. For example, if we were treating an L5-S1 disc herniation, our primary thought is just on addressing L5-S1 because we are not going to be treating any other level until the sciatic radiculopathy caused by the disc herniation is at least 50% reduced. If we are treating a patient without sciatic radiculopathy, we're going to test all lumbar levels, even into the thoracic spine, because we're going to be addressing more levels in a patient who does not have sciatica, called Protocol 2. So in central tolerance testing, number one, because you don't know how much tension for sure is on this caudal section, when you release the caudal section to begin central tolerance testing, always place your thigh against the caudal section, hold the tiller bar, release the flexion lever, and then just adjust the tension so that when you press down, that instrument will just that easily return to neutral. Okay? In central tolerance testing, if it is a sciatic patient, we're going to begin in an upper lumbar segment. Like say it's an L5-S1 disc herniation, we're going to begin at the L1 level. We're going to contact that spinous process. You're going to have your body, your nose, right over the middle of this caudal section. You will apply the same force under the spinous process here as you apply with the caudal section in flexion distraction and decompression. And we will hold the spinous, move down over the caudal section, only using the patient's weight as attractive force. So we hold, we move down 1 to 2 inches. We hold for 4 seconds, and we ask the patient if this causes any increase in back or radicular pain at all. If it does, that means that we will have to begin treating that patient without even contacting the spine. We will apply flexion distraction or even long y-axis distraction without any contact on the spine. Now that's a very rare patient. I can't remember having seen one of these even. But if it did, you would begin by using physiological modalities, positive galvanism, interferential current, sine wave current, ice. Get this patient relaxed, maybe even acupuncture in that really severely acute patient who can't even tolerate a spine contact to tolerance test. Very rare patient. So if we do central tolerance testing and they do not complain of pain radiating into the lower extremity are increasing pain. Now they may increase a little pain under the spinous because of the dorsal ramus irritation. In that case, put more pressure on the thenar and the hypothenar paravertebral contact in order to spare the pressure on the spinous process. Now, when we do tolerance tests, and we are starting at L1, we will first move down. No pain, we'll move to L2. No pain, we'll move all the way down to L5. And we will ask that patient if any of those areas cause them pain under central tolerance testing using lower extremity weight. If you were treating a specific disc herniation, you know it's say L4 or L5, you are going to contact the spinous above that disc herniation, never below, always above, and apply central tolerance testing and very carefully monitor if there's any increase in back or radicular component. If there is no pain on central tolerance testing, next we will do lateral tolerance testing. In lateral tolerance testing, you will grasp the ankle of the uninvolved lower extremity. For example, if they had left lower extremity radicular pain, we will hold the right ankle, contact the spinous above the disc that we are going to decompress, and move this thenar to that side over the mammillary process between the spinous and the transverse process, so we were challenging the facet joint and the nerve root on the uninvolved side. So we will hold that contact, the ankle, move down 1 to 2 inches, and ask if that increases low back or radicular pain. If central tolerance testing did not cause pain, however, lateral tolerance testing did increase back or leg pain, then you will begin by only using central tolerance testing compression. That is, treat the segment as we go into protocol 1 and 2, only using lower extremity weight. Do not use the contact on the ankle and the spinous. So we tolerance test the uninvolved side first, then move to the involved radicular segment. Contact the spinous above, contact the ankle, apply 1 to 2 inches of distraction, again the same force here as at the ankle, and tolerance test if that increases low back or radicular pain. If it does, we would not begin by holding the ankle and the spinous process. We have done central and lateral tolerance testing. If there was no pain, and you're going to go through patients, and there's only going to be about, in my experience, less than 4% of people who ever complain of central or lateral tolerance testing. If there is not, your decision is twofold. Number one, you can continue to treat with lateral tolerance testing forces, or you can move to tolerance testing with the ankle cuff in place. Now, when you place the ankle cuff on the patient, always lock the caudal section of the instrument. The reason being that if you were to just lift the patient's lower extremity, this may move the caudal section into extension, and in stenosis, regardless of the etiology, it might aggravate the low back or leg pain. Having made that mistake, you can believe that you should lock the caudal section before you move down to place the ankle cuffs on the patient. When you do the ankle cuffs, always make sure that we get them equal tightness. Don't make one loose and one tight, else you're adding an obtuse type of decompression to the low back. So make sure we get equal force on each ankle. Now you can also bring the tiller bar to a taut point, so that when we're starting to treat, we have most of the tautness taken out of the ankle, the knee, the hip joint. We're ready to treat the specific segment. We will next tolerance test with the ankle cuff in place. We release the flexion lever. Contact, if it is a disc herniation case, contact the spinous above the disc that you are treating. If you're treating a disc herniation at, say, L3, L4, and L5, always make sure you contact at L3 above all of the disc herniations you are treating. Never contact a spinous below a disc herniation, else possibility of bringing the disc herniation or fragment into contact with the nerve root or the dorsal root ganglion and aggravating the patient pain. So if we're treating specifically an L5-S1 disc, we will place the thenar on the L5 spinous process. Don't get your own wrist at too sharp an angle, else you create carpal tunnel aggravation on the median nerve. This arm is straight. We move to the taut point and we apply 1 to 2 inches of downward force on the caudal section and ask the patient if that aggravates their low back or radicular pain. If this did aggravate the patient and holding the ankle did not, then we would begin by holding the ankle. Always treat below patient tolerance. Never ever enter the danger zone where a patient complains of pain on tolerance testing. So if we're treating a specific disc, we just tolerance test at that level. But if we are treating what you're soon going to see called Protocol 2, then we will test all levels of the lumbar spine. If you don't have radicular pain, it's okay to start at L5 and tolerance test 5, 4. You okay there, Chris? And always monitor the patient. Ask if this causes them any back or radicular pain. And you can even move all the way up into the thoracic spine tolerance testing, because we are going to treat, as you'll see in the video, thoracic using the caudal section. You okay there, Chris? So once we see that the patient tolerance tests well with the ankle cuff on, and believe me, this is most of the patients. However, you can still very effectively treat patients without the ankle cuff using either central or lateral tolerance testing forces. But using the ankle cuff, we'll use slightly less force on the part of the doctor because of the long y-axis distraction is increased with the ankle cuff on compared to without it on. So having tolerance tested, and we're going to see with this patient we had no complaints all the way with the ankle cuff in place. The next thing before we begin treating is to learn what we call the taut point. The taut point is the new starting point to apply flexion distraction or long y-axis decompression. What I mean by that is this. When you make a contact, say we're treating an L5-S1 disc, thenar on the L5 spinous process, equal force here and on the tiller bar. I'm over the patient, centered over the patient's spine. This arm is straight, this arm is straight. When you move down with this caudal section and lift this spinous process, you reach what is called the taut point. That is the point of barrier of elastic resistance. We have taken all the tautness out of the ankle, the knee, the hip, any individual vertebral segment below our hand contact. And it is at that point that we will apply flexion distraction and or long y-axis distraction and decompression for either Protocol 1 with radiculopathy or Protocol 2 without radiculopathy. Let's reiterate that again. I move with equal force here and on the tiller bar to this taut point. And when we treat, we start at the taut point, we apply flexion distraction, or we apply long y-axis distraction, and when we return, we do not go beyond the taut point. If I move down with this contact, taut, and now I apply flexion distraction, I'm entering a paraphysiological zone. I do not go beyond the loss of tissue integrity where we cause pain and tearing of soft tissues at an individual vertebral segment. So we move to the taut point, and just to exemplify that to you, let me just show you how that is. If I'm treating a spine that's relaxed, we don't start and treat a patient like this. We're not pumping water or milking cows. We bring that segment to the taut point, and it's from that taut point that we apply flexion distraction or long y-axis decompression. So that imagine with this contact, I move to the taut point and I apply flexion distraction, whether it be protocol 1 or 2. Protocol 1 is the patient who has true radicular pain, meaning it is isolated to a specific dermatome. The pain extends below the knee. You have orthopedic neurological signs. You have a straight leg raise, which is 50% reduced on the side of radiculopathy compared to the opposite normal, and or you may also have positive imaging such as MRI, CT, or myelographic enhanced CT scans. But in applying protocol 1, meaning that we have spinal stenosis, whether that spinal stenosis, say, be caused by a disc herniation or by hard changes like facet arthrosis, ligamentum flavum hypertrophy, bulging discs, end plate hypertrophy, or usually a combination of all of these. But when we treat with protocol 1 for radiculopathy, we only use protocol 1 until 50% of the radicular pain is relieved. That is, it will begin to centralize above the knee. The VAS, or the relative value of the pain in the lower extremity, diminishes by at least 50%. That if they had a VAS at first of 10, it reduces to 5. We now shift that protocol 1 radicular patient to a protocol 2. Now that's not necessarily born in rock. I mean, it's a clinical skill for you and for me to determine when we can move from protocol 1 with a patient to protocol 2. It has always, in my opinion and finding, been safer to wait till 50% improvement before you start protocol 1 to protocol 2. Protocol 1 only uses one movement of the instrument, flexion distraction and or long y-axis decompression. Looks like this: radicular patient, spinal stenosis, disc herniation, or degenerative change. Thenar above the segment that is protocol 1 radicular patient. You've already tolerance tested. You know what that patient can tolerate. In treating protocol 1, you will place equal force on the spinous and the tiller bar. You move to the taut point, and we apply the first 20 seconds of decompression. And each 20 seconds consists of 5 4-second pumping distractions with the instrument. Applied manually, look like this. Taut point. You okay, Chris? I ask patients all the time if there's any discomfort. And I apply the 5 4-second pumps. Now note that 4 seconds means you're down 2 and up 2. Looks just like this. The force on the thenar, on the spinous, and the force on the caudal section tiller bar are equal. Between the 3 20-second distractions, and we apply 3 20-second decompressions, each 20 seconds consisting of 5 4-second pumps. Between each of those, we will treat acupressure points B22 at L2 down to B35 at the coccyx, then move out to B49 in the retrotrochanteric space, incidentally where the sciatic nerve is almost an inch in diameter as it passes through the egoic area, the gemelli obturator internus muscles. So we will treat these acupressure points from B22 at L2 through the lumbar spine, and as you know, we hit many sore spots here. And we move down over the sacrum to B35 at the coccyx, move out to B49 behind the retrotrochanteric space. And as you know, many people have sometimes most of their pain in the retrotrochanteric area. Then we move down through the posterior thigh, and these are bladder meridians. And we stop at bladder meridian point B54 in the popliteal fossa, where the tibial nerve is quite superficial. This can be a very tender acupressure point. You may use needles, we use pressure, needles, whatever works. And between each of these 20-second distractions, we apply the acupressure points. On this video, I will not go into the use of physiological therapeutics. Galvanic, tetanizing current, they're in the textbook. You can read that part because this tape could go on for days otherwise. After treating the acupressure points, we make that second contact. We apply force equal with the thenar, equal with the caudal section to the taut point, and apply that second 20 seconds of decompression consisting of 5 4-second pumps. Look like this. Taut, 1, 2. It's smooth, rhythmical, and oscillatory. When you take certification, those of you who have or those of you who will, who really get into this technique, you know that we put a transducer on the spine. We allow you to measure the newtons of force that you're applying in the XYZ plane so that you can map on a video screen the sine wave of how much pressure you are applying, so we all know exactly how much force to apply to a patient within a safe range of newtons of force. Okay. So in treating the Protocol 1 radicular pain, we apply the 3 20-second decompressions. This is done manually at the outset, which you've seen me do. Manual contact, taut point, 5 4-second distractions. Now, as soon as this patient begins to show good relief of lower extremity pain, I mean, say a VAS drops from an 8 to a 6, you can then begin to tolerance test again for, instead of manual, using long automated y-axis. Via V, on this tiller bar behind the handle is a little button that you press down with your middle finger. And I can apply the 5 4-second pumps utilizing the long y-axis distraction component of the instrument. It makes it equal, steady, oscillatory, and rhythmic. So you can begin to apply long y-axis distraction to this individual segment. We also, to lead you to the next step, in a radicular as well as we get to Protocol 2, as soon as this leg pain is beginning to centralize, diminish, show you that the patient's really turned around with the amount of discomfort they have, we will then begin in applying our physiological therapeutics such as positive galvanism, interferential, sine currents, heat, ice. We will then begin to apply those modalities while the patient is under long y-axis decompression. Now, many of you hear a great deal about what are called decompression instruments. I mean, they seem to be like this is something new, you know. There's nothing new about this. We do that all the time with Cox technique. But we don't start with an acute low back radicular patient using anything automated. We always start manually so that we are under total control. If there's any discomfort, the patient can tell us. We can stop at that force and reduce the amount of decompression so we avoid iatrogenesis, you know. As soon as we see good relief of the leg pain, we will then begin to apply the modalities under unattended long y-axis distraction, via V. On this tiller bar is a button that says automated. Okay. On the side here is a computer that we can set the depth of distraction, that is how far this caudal section will move, anywhere from 1/2 to 2.5 inches at half-inch increments. So I typically will set this at 2 inches. Right there, it's set for 2 inches, and this is the timer. I typically will set it for the 12.5 minutes. With it set at the time and the depth of distraction, we will then have it set at automated, and press the start button, and the instrument will now apply unattended long Y-axis decompression that you hear so much about. And we can also be applying physiological therapeutics to the spine, the galvanic, tetanizing, interferential currents to take out inflammation and sedate the inflamed nerve, the chemical radicular component of radiculopathy. Now, also with the instrument, and something that I use myself a lot in clinical practice, is the thoracic and lumbar restraint. If you want to isolate the decompression force to a specific level of the spine, you can use the thoracic restraint. Merely bring it over the patient, attach it to the opposite side, and by placing this at any given segment, given level, we can isolate the distraction force to that segment or that individual level of segments that we want. This is a feature that is new with the instrument that you will use with increasing rapidity in your own practice. Patients so often say, you know, doctor, it would feel good if someone would just pull me apart. I say to them in a very kind and loving way, oh, I'm going to pull you apart very gently. Okay. So we tolerance test the patient. We have the thoracic restraint. If you're treating any given spine, you just spine level, just make sure the thoracic restraint isolates to that segment so that it is only that segment and caudad to it that is being distracted. Okay. You can set that. You can allow the decompression to take place. You can apply the physiological therapeutics. And then, when we get into Protocol 2, you're going to see that we will begin under long Y-axis decompression to apply physiological ranges of motion to the spine. Now, let's discuss something. In a given day of clinical practice, the number of people that you and I treat who have full-blown sciatica is certainly less than the number of people that we see who do not have full-blown sciatica. For some of us, we see far more sciatic patients because you tend to attract what you think about and I think what you're really good at treating. So in any practice, though, we're going to see far more people per day who do not have true sciatic radiculopathy. They have low back, buttock, and sclerotogenous pain. Pain in the buttock, low back, it does not radiate below the knee. These are what we term Protocol 2 patients. They are treated with long Y-axis distraction, and while under long Y-axis distraction, we place their facet joints into their physiological ranges of motion. Earlier in this tape, we showed you those movements performed with the caudal section. Now we'll show how they are actually performed on our patient. When we use Protocol 2, we always use long Y-axis distraction first because we want to open the disc, increase the foraminal area, drop the intradiscal pressures so that we make the canals patent, open them up before we place joints into lateral flexion or circumduction. The reason is quite obvious. We don't want to lateral flex an already stenosed nerve root. We destenose it, then place facets through physiological range of motion. We always wait until the radicular pain is at least 50% gone, if it is present at the outset, before we apply these other physiological ranges of motion. Let's talk about the spine contact in Protocol 2. It's done in two ways. One is with the thenar, the other is with a thumb index contact. Each of these has its own preference, which is primarily up to you, the treating physician. The thumb index is a good way to begin if you were just starting this technique because it is quite specific. Thenar, on the other hand, is probably more comfortable to the patient themselves. So when we're doing protocol 2, we've already tolerance tested the entire spine. We can start at L5 with either a thenar or a thumb index contact. We can apply either manually, flexion distraction, or unattended long y-axis with the tiller bar. And we can control spinous interspace decompression and facet joint movement with either this thenar contact or the thumb index contact. I prefer the thenar myself, but some of you I know will prefer thumb index as well. So when we are treating patients with low back, buttock sclerotogenous pain, no radicular pain, we can decompress, place their faucets through all physiological ranges of motion. It looks like this. Long y-axis first. Release the lateral flexion lever. And while under long y-axis, we can apply lateral flexion. And you control the movement of lateral flexion with your thenar or your thumb index by holding the spinous process, applying long y-axis, then lateral flexing. And as I move to the left, I resist the spinous with my index contact here. And as I move to the right, with my thumb contact here. If I use thenar, no problem. Hold, move to the left, resist with the thenar on the left spinous. Move to the right, resist with the hypothenar piezoform contact. So I can do long y-axis with lateral flexion one of two ways, either dynamically by combining the two, or I can bring the patient into long y-axis distraction and lock the table under distraction, and then while under decompression apply lateral flexion. Now, I'd like to share something with you. When you treat an acute lumbago patient, this is how you want to begin. You don't want to be forceful with these acute low backs that are in spasm. Their muscles standing out there in the low back. They're slightly flexed in a kyphotic sagittal curve. Begin by applying just lateral flexion. You can get by with this, but if in an acute disc, if you add too much long y-axis decompression, it aggravates them. And all of you will witness that if you use this technique very long. That if you take an acute lumbago and do this technique, it's too much for them. Far better to start out with using lateral flexion. Then as they tolerate that, apply a little bit of long y-axis, lock the table under long y-axis, and apply lateral flexion while we've applied long y-axis, then apply the lateral flexion in a coupled movement. Okay. Now, in a patient who is responding quite well, they don't have too much low back pain, we apply the movement of circumduction, but you wait to use circumduction until the patient, as you tolerance test them, says, no, it does not aggravate me. Circumduction looks like this, doctor. I'm going to use that electrical foot switch on the side of the foot base to apply long y-axis distraction. Looks like this. So I first apply long y-axis distraction, then apply long y-axis with lateral flexion in a smooth rhythmical coupled movement. And now watch the next movement. I apply long y-axis, flexion, and lateral flexion in a smooth rhythmical coupled movement. And this is called circumduction. In some of the literature on manipulation, and I've written it myself, the patient who can tolerate circumduction, that is long y-axis, this movement, lateral flexion, and then combining them into the movement of circumduction, is a healthy articulation. We've reduced stenosis, We are now placing the facet joints through their physiological range of motion. And while it's not the purpose of this tape, in lecture you're going to hear that we talk about afferentation of stimulating faucet and disc receptors, mechanoreceptors. We're going to talk about dorsal root ganglion, small and large myelinated A fibers, and the small unmyelinated C fiber stimulation when we do this technique, and how it treats the chemical radicular pain and the brain chemicals when we do this. But we're not going to go into that in this visualization of how to do the technique, but realize that's an extremely important part. So you've seen in Protocol 2 that we can apply all of the physiological ranges of motion. Could I talk about some specifics for you? Let's take the patient who has DISH. They have degenerative disc disease. They have facet arthrosis. They have spinal stenosis. But they don't have true radicular pain. It doesn't extend below the knee. There are no motor sensory reflex losses. The patient is really quite ambulatory, but they have a lot of this low back and buttock pain. And as you know, sometimes the GOIC, the gemelli obturator internus complex, the posterior hip muscle group, the gluteals, the obturators, the gemelli superior and inferior muscles, the obturator internus can be very, very painful in low back and sclerotogenous patients as well as radiculopathy patients. So for the use of this table, and we're talking about many patients treated each day in our clinics who come in with low back, buttock, radiating buttock and thigh pain, and you know we see these all day. Here's another approach that I use to protect your time as a physician and yet to maximize the benefit for the patient. Lock the instrument. We will place the thoracic restraint on the patient, and patients do truly appreciate the feel of long y-axis decompression. So if they come in and they have the whole lumbar spine is degenerated, they have spinal arthrosis, they have spinal stenosis, no true radicular pain, put the thoracic restraint on as we show here. Bring this over, you merely slip it through the loop, and then determine how much of the spine you want to decompress. Do you want to start up in the thoracic spine and apply mid and lower thoracic as well as lumbar decompression? Do you want to isolate to say L3, L4, L5? Determine the segment or segments that you wish to place under long y-axis decompression. And merely determine those levels, place the thoracic restraint, and then we will set the instrument under automated. Here, we will set our distance. I usually almost always use 2 inches. And the timer, press start. And what we are doing now is to apply long y-axis distraction. And while we do this, we can apply tetanizing current to the paravertebral muscles that may be spastic and painful. We can apply positive galvanism or interferential current to any specifically inflamed dorsal root ganglion or nerve root. And the patient can go under, say, 12 to 15 minutes of unattended long y-axis distraction, have physiological modalities applied, and then towards the end of that, you can come into the room and our assistants can hook the patients up for us. We can come into the room and do the spinal adjustment. And yes, Cox flexion distraction, long y-axis decompression is a chiropractic adjustment. And we release the lateral flexion lever, and then as the patient undergoes long y-axis distraction, we can apply physiological ranges of motion to the facet joint, just as we did earlier manually. We can also release the flexion extension lever, and we can even apply while under long y-axis decompression, we can apply circumduction to each of these spinal segments. Let's talk about spondylolisthesis in transitional vertebrae for a moment. You can read the text, but I'd like to summarize in finality that when treating these conditions, you always contact the spinous process above. There's no reason you cannot do unattended long y-axis decompression as shown here. But when you do adjusting, certainly don't place PA pressure on a spondylolisthesis, and there's no sense in contacting a transitional segment whose discs and faucets are rudimentary, right? So always, you can do the technique, but always treat above these conditions, okay? The use of Protocol 2. Now, whenever you want to stop long y-axis distraction, you merely press the button on the tiller bar and it will move back to detente and stop for you. Lock all of the locks. Okay. I'm going to move this tiller bar down. I'm going to remove the thoracic restraint. I think you get the idea of how much value this particular procedure is to you in the majority of people we treat each day who do not have radiculopathy. I'd like to discuss with you about treating people who are in so much pain that they can't lie on the instrument, or they're pregnant. The pregnant female cannot lie on the abdomen. So I'd like to share with you side lying technique for a moment. And I have patients, and some of you will also have them, who actually prefer to be treated side lying as opposed to lying prone. So Chris, if you would turn on your side facing me, please. Okay. And then you'll place a pillow underneath the head for patient comfort. We flex the knees, and I'm going to bring Chris down. I need his pelvis on the caudal section, right here. That's wonderful, Chris. Okay? Bring this tiller bar up. And their ankles will just gently rest against the tiller bar. Now, we'll bring the patient, to spare your own back, you will just bring the table up so that you don't have to bend and twist your own spine. Remember, think smarter, not harder. So, in side lying, we can perform manual flexion distraction, we can perform unattended flexion distraction, and we can even apply Protocol 2. It's not as forceful, but the reason they're on their side is because they couldn't tolerate that much force. And there are some people who really appreciate this type of gentle manipulation. I bring the patient's arm here, bring mine through just to stabilize the patient. Release the lateral flexion lever, and by contacting the spinous process between your middle and index finger, we can control flexion distraction. Using my left knee as the forceful here, I can apply long y-axis flexion, or watch this, using the electrical stripe, I can apply long y-axis and flexion in a smooth, rhythmical, coupled movement. Side lying technique. If you are treating spondylolisthesis, for example, in a side posture contact, you'll contact S1 and L4 and apply flexion distraction in this side lying position. You can also do Protocol 2 side lying. In this case, we will release the flexion extension lever. Okay. Increase a bit of the tension on the tiller bar, and we can do circumduction and lateral flexion under long y-axis distraction with the patient lying on their side via V. long y-axis, and flexion in the side lying position, long y-axis, left and right in the side lying position. Okay? Right. We can apply circumduction via V, contact the spinous, and by controlling the spinous process, we apply circumduction. Scoliosis. If, and one of the conditions that you will use this technique in is in degenerative scoliosis of the thoracolumbar spine, usually seen in people age 50 and greater. And I think you can visualize the patient. She's 60 years old, has scoliosis from T9 through L4. On the concavity of the curve, they have osteophytosis with ankylosing spondylosis changes. Put the curve down. Like let's say this was a levorotatory thoracolumbar curve. Contact with your fingertips between the spinous and transverse processes, and we will lift with these contact while we apply lateral flexion into the convexity of the curve, while at the same time we apply long y-axis decompression with lateral flexion into the convexity of that curve. Of course, we are tolerance testing. We ask the patient, do you have any pain at this time? And we constantly tolerance test this patient. Side lying techniques, we can do any of the techniques side lying that we can do in a prone position. Allow me to take a minute to share something about supine manipulation with you. Supine technique. There are a couple of conditions that I use this technique in, and I know some of you do, so let's share them. Let's take that same patient that we were just discussing in side lying technique. He or she has dextro or levorotatory scoliosis of the thoracolumbar spine, a lot of ankylosing osteophytosis on the concavity of the curve. Many of these people will respond best supine, via V. We place the pelvis on the caudal section, thoracic spine on the thoracic section, release the lateral flexion lever, and always place the hands here, and for impropriety with the female, put your hand on top of theirs in order to control distraction and lateral flexion movements. So I can take that patient, let's say that they had dextrorotatory thoracolumbar scoliosis. I can first of all apply long y-axis distraction, holding my contact here, and just very gentle, and certainly this is gentle, but that's what we want for this type patient. We apply this distraction, pelvis distracting from the thoracic spine here, and I decompress the curve first, increasing the intervertebral disc space, increasing foraminal area, dropping intradiscal pressures. And in this right rotatory thoracolumbar scoliosis, I can begin to apply lateral flexion and long y-axis distraction into the convexity of that curve. Okay. Very gentle, very controllable. I can constantly see the patient's face, and I can ask, does this cause you any discomfort? Okay. Let's take the other condition. We see a lot of Kummel's disease, post-traumatic arthritis, compression fractures due to osteoporosis, and they're just increasing all the time. One reason being that women, and men too, refuse to take calcium, vitamin D3, zinc, vitamin K, and sometimes even strontium citrate. They don't follow the directions, at least for me so often. So we end up treating a lot of compression defects, osteoporotic spines, and certainly in treating osteoporosis, these very gentle techniques are superior. But in people who have these conditions, osteoporosis, and they have compression fractures, have them lie on the back and just apply long y-axis distraction. And then, with the flexion extension lever released, just tolerance test by placing a bit of extension on that thoracolumbar spine as I am, and say, does that cause you any discomfort? And you can look at them and see them and ask them, and then apply a very gentle long y-axis with extension of that kyphotic gibbous type deformity caused by loss of vertebral height due to the conditions just mentioned previously. So some of the very gentle techniques that you can apply in the supine position. Some of these patients think that just this feel is enough being decompressed to give them relief. The sacroiliac joint. It is my preference not to use side posture adjusting. So in adjusting sacroiliac joints, I do them using drops and adjusting SIs under long y-axis distraction. Via V, let's say that we are dealing with a posterior ilium on the right side. I can have the cuff on the patient. I can cock the sacroiliac, I can go ahead and just set the instrument with the drop under the proper tension. And as I apply long y-axis, you don't use any thrust. You merely use the electric foot switch. Let this patient move, and under long y-axis, as they decompress, the minimum force will cause the posterior ilium to adjust. Visualize again, please. Here. And we adjust sacroiliacs using the Clay Thompson drops. And if it's an anterior ilium, again, we can apply it. This is how I do. I apply it into the ischium, a PA force, apply long y-axis, and adjust the anterior ilium under long y-axis. Just hold the contact, allow it to decompress, and adjust the anterior ilium and the posterior ilium under long y-axis. And as you apply long y-axis, you just keep the constant force, and as it decompresses, the sacroiliac will adjust for you. Thoracic spine adjusting. To me, one of the heralded favorites of my work is adjusting thoracic spine under long y-axis decompression. I don't know how many of you have ever experienced, whether it's 100 or 110% of you, but when you come into a thoracic spine and make the setup, so often when we thrust, nothing moves. The patients just kind of tighten up, and you know that it aggravates them. Even if you adjust here and they have stenosis in the low back, it can even increase low back and radicular pain. So I'd like to offer you another way of adjusting costovertebral and thoracic spine hypomobility subluxation. Do it under long y-axis distraction. Ankle cuffs in place. Make the contact. And using the electrical foot switch, I'm applying long y-axis distraction and just making the contact on the thoracic segment that we want to adjust. No thrust. Just hold, and as we increase the disc space height, decompress the facet joint, and lower intradiscal pressure, these facets will begin to cavitate. They will move under long y-axis by no thrust, just making this contact and allowing the smooth, rhythmical, oscillatory movement of the instrument do the adjusting for you. Now think about DISH. Diffuse idiopathic skeletal hyperostosis, osteodegenerative arthritis. Do you feel that, Chris? Osteodegenerative arthritis, degenerative disc disease, conditions that you know you thrust them, nothing will move. When I do this, you begin to get cavitations more than you will get by forcefully using high velocity, low amplitude thrust. And while there's nothing wrong with high velocity thrust adjusting in people who can accept it, we are seeing more and more people with stenosis, degenerative spine disease, who will not tolerate that. So just do this and then ask that patient the next time whether they'd rather have adjustment this way or with a high velocity thrust, and I believe we'll learn quite a bit. I'll do more on thoracic adjusting on the cervical part using the occipital restraint as well. But in adjusting thoracic spine, this is the most gentle, well-tolerated form of spinal adjusting for thoracic spine, annihilating iatrogenesis and discomfort for the patient and incidentally for the doctor as well. I'd like to end the low back section of this tape with the foramen magnum pump. This is a technique that I've learned from osteopathic literature. My stepfather, as I've said many times, was an osteopath, and I learned a great deal from him. My chief of staff at National was an osteopath named Floyd Blackmore. I studied osteopathy. I blended it with chiropractic. That's what you see here basically in this video, is a combination of what to me was the best of these two professions. I learned the foramen magnum pump from osteopathy, and it consists of placing the basi-occiput in your contact hand, and I end every adjustment with this. You hold, and with the ankle cuff in place, we apply long y-axis distraction from the basi-occiput through the entire spine. The foramen magnum pump. For some patients, they think this is the best part of the adjustment. As we move into the cervical spine, we'll see that we incorporate this into so much of our treatment of the cervical spine. And the last point that I'd make, just to impress upon you the effect of using long y-axis distraction spinal manipulation, is this. If you just watch a spine under long y-axis, put your fingertips between the spinous processes, feel that dynamic mobility that takes place, and then consider that under that mobility we apply specific level spinal adjusting depending upon the condition. You have the powerful weapon of decompression and flexion distraction adjusting combined. We will next move to the cervical spine. In 2002, my wife developed right C6 radicular pain. And she said to me, she said, "Now Jim, what you do in the low back, I want you to fix this disc in my neck." And I said, "Oh no, that's a whole new life's work." And of course, that was the wrong thing to say. And so we developed the cervical headpiece, which we'll share with you at this time. So I call this Judy's headpiece because she actually instituted the development of it. When you use this headpiece, it's like nothing you've ever done before. It is the most exciting part of Cox's work, in my opinion. When I first developed this, I thought maybe we would treat maybe 20-30% of the people. We'd use it for cervical spine treatment. Today, it's half of the people or more. Because when you treat the neck, I find it to be mentally for me a greater stress and more painful for a patient. Because when we treat the cervical spine, we have a 7mm spinal cord sitting at C5, C6, the most common level of disc herniation. We develop arm pain, muscle weakness, reflex loss. To me, to treat these cases are the most challenging and the most demanding of our technical skills. And so this part to me is quite important. Let me share with you what this headpiece can do for you in your clinical practice. First of all, long y-axis distraction is the primary feature of this instrument. This is long y-axis. Now you will note that they have some name for this apparatus. I don't know what it is, but I know one thing. It moves very, very smoothly. You'll never see anything like this on another instrument. You'll never see it on another instrument. But that's how smooth that cervical headpiece applies long y-axis distraction. As I share the technique with you, you'll see that this is probably at least 60% of the treatment of both Protocol 1 and Protocol 2 patients. That is, those who have radicular upper extremity pain and findings, and those who do not have pain extending below the elbow. So this lock controls long y-axis distraction. You can stop it at one of 5 detente points to apply a given set of decompressions. This movement is the lateral flexion, and you can combine in a coupled movement long y-axis and lateral flexion. This movement is flexion and extension on the headpiece. Okay. This one locks the long y-axis. This locks flexion and extension. Okay. On the front of the instrument is the lock for rotation. And note that when you use rotation, it doesn't require any effort on our part to rotate. The instrument moves with no resistance to our palpatory skill. Okay? And you'll see as we treat, we combine all of these movements in Protocol 2. So these are the movements of the headpiece. The tiller bar will recede out of the way and move back up to any given height that you want. You will see that we use occipital restraints, and these go over the patient's occiput to allow us to apply long y-axis distraction for Protocol 1 and Protocol 2 with full range of motion using the occipital restraints. And then you'll also see that we adjust the thoracic spine with the occipital restraints in place. And vis-a-vis that, when we place these straps, there on the bottom of the headpiece is a piece of Velcro that will attach to. And here, wherever these two cross, will be the place on the patient's spine that you are applying long y-axis distraction. And so we will now proceed with showing the actual demonstration of how to use the headpiece. Lastly, realize that people have different facies. You will want to set the opening of the headpiece to match the zygoma and the frontal bones for the patient and the nasium. And you do that here. Patients will learn to run this. They will set it to the comfort size of the headpiece that fits their particular need. When we're ready to place the patient on the instrument, we place the face paper in place, and there's a holder in the bottom that holds the paper in place. When the patient lies down, we want their eyes right here. There's a 4-inch cutout of soft material so the patient can leave contacts in and it will not aggravate them. So with the patient, we ask them, lie on your stomach with your eyes right here. And so why do we want the eyes right there? Well, because it places a C5, C6 disc space right here at the caudal end of the cervical headpiece. It's in the proper place for the fulcrum movement when we use long y-axis or physiological range of motion to each segment of the cervical spine. It also gives them comfort for the eye. It gives us the best placement for decompression long y-axis movement of the neck. Tolerance testing. Again, just as in the low back, we always tolerance test the patient's ability to withstand long y-axis distraction and flexion distraction manipulation. Now, these levers are on both sides of the instrument. This one releases long y-axis. So in tolerance testing for Protocol 1 or 2, we always use long y-axis decompression as the challenge test for patient tolerance. Start with the foramen magnum pump. Grasp the basi-occiput in the index thenar contact. We apply equal movement with the tiller bar and this contact. They move in parallel. One doesn't move more than the other. No, they move with equal force in the cephalad direction. So we contact the basi-occiput, we apply long y-axis decompression, and we ask the patient, does this cause you any neck, shoulder, or arm pain? Typically, you're not going to find people that complain of pain. They typically say, no, doctor, it feels good. But we have to tolerance test carefully on every patient on their initial visit. And we tolerance test, we ask them throughout the treatment, are you okay? Do you feel any discomfort? So we test first, long y-axis, we apply decompression to the basi-occiput. We move to C1, C2, C3, 4, 5, 6, and 7, applying long y-axis. And then when we get to T1, we just place the spinous between our thenar, hypothenar, and we apply long y-axis distraction from each of these thoracic segments, just tolerance testing. Does this cause you any discomfort? And we can move all the way down through the thoracic spine, carefully tolerance testing down to about the T9 level. In treating with Protocol 1, people who have radicular arm pain, we only use one movement of the instrument. That is long y-axis distraction at the involved cervical disc herniation, or, as some of you like, you'll use flexion at that level. Let's look at each of these. My preference always is long y-axis. I hardly ever use flexion and extension in the cervical spine. I only use it in the thoracic spine where I use extension. In treating Protocol 1, since C5, C6 is the most common disc herniation that you and I treat, we'll use it as an example of treating radicular pain, in this case C6 radiculopathy, due to a C5, C6 disc herniation. When you treat, you will place the spinous process of the vertebra above the disc herniation right here at the web of the thumb-index contact. You will close down on the arch of that vertebra with the thumb and the index just like a vice grip. A very gentle yet firm contact, looking like this. Contact C5, close down on the contact. This hand and this tiller bar moving in parallel, we move to the taut point. That is the point at which you feel all of the tissues come to tautness. Remember, in the low back we mentioned that we bring the spine to the taut point. And it's from this taut point that we apply the long y-axis distraction or apply lateral flexion, circumduction, flexion, and extension to the segment. At C5, C6, with that strong contact, now please observe, the way that you address C5, C6, or any segment of the neck with this contact will determine whether you are increasing sagittal lordosis or creating sagittal kyphosis. You can increase or decrease the lordosis of the sagittal curve of the neck by this contact. If I use a PA force as I apply long y-axis, I'm increasing cervical lordosis. That's fine if I'm treating a non-radicular patient without stenosis. But if I'm treating a disc herniation where I want to drop intradiscal pressures, open the posterior disc space, then I'm going to lift that contact as I apply long y-axis distraction, V of E. If I contact a C5, arch, and then if I apply long y-axis and lift this contact, I'm decreasing cervical lordosis and increasing the posterior disc space and the osteoligamentous canal size, this contact. So when I apply Protocol 1 for a radicular patient, the only movement we're going to use is long y-axis or flexion, looking like this, with the contact spinous index thumb over the laminae of C5, I move to the taut point and apply the 5 4-second pumps that look just like this. Just like this. That's the force that we apply for Protocol 1. Now you will need to read the text. You will need to see this demonstrated and work with you to apply the proper forces. I'm showing you, though, the technique for your introduction to this work. Strong contact, taut point, the 5 4-second pumps look just like this. Make sure that this hand is moving in a direct cephalward direction, not in an obtuse angle. We want to lift straight and not create any abnormal angulation of the spine. Protocol 1. And we will use this particular technique until we have at least 50% relief of the radicular pain before we move to Protocol 2. Now, I did mention that in addition to long y-axis, which is my preference, some people do like to use the flexion component. So in that case, you release the flexion movement of the headpiece, you'll contact the C5 arch, and you'll apply flexion for during the 3 20-second decompressions, and each 20 seconds for a radicular patient consists of 5 4-second pumping movements. So this is using flexion. Some of us will even use both of these movements, utilizing long y-axis and flexion. I don't personally do this, but I've known some chiropractors who like it. They'll use long y-axis and flexion in a coupled movement. To me, it's stronger than you need. I don't think we ever cause any iatrogenesis by undertreating, only if we overtreat. So for me, I use only long y-axis, but I do realize that some of my colleagues say, Jim, I like to use flexion. I just hope that with use they maybe drop that attitude. So the instrument is locked then, having performed Protocol 1. In Protocol 2 of cervical spine, we have a patient who can have neck, shoulder pain. And remember the work of Dwyer, Bogduk, and April? Facet joint irritation will radiate pain as far as the inferior scapular line from C6-7 and C5-C6 facets. It'll radiate into the neck, even into the front of the chest, and up into the face when we are dealing with C2-3 and C3-4. So all of this radiating sclerotogenous pain is treated with Protocol 2. And you'll admit that in your daily practice, the majority of people we see have neck, shoulder pain, but they don't have full radicular pain. So you're going to be using the following technique on the majority of neck and shoulder patients, as opposed to just using Protocol 1. But in Protocol 2, which is probably the most patients we treat a day anymore, we're using a combination of long y-axis, lateral flexion, and rotation. And it looks like this. So we have a patient, and you know this patient, they have degeneration at 3 or 4 cervical levels, say C3, 4, 5, and 6. In that case, with no radicular pain, we will contact the arch. We will apply long y-axis distraction. Say we're treating C3, 4. C3 spinous here, laminae here. We apply long y-axis distraction, and then dynamically we'll apply long y-axis and lateral flexion in a smooth, rhythmical, coupled motion to the left and to the right. Then we can also apply rotation. Long y-axis distraction, lateral flexion, and rotation. And when you rotate, this hand is rotating that vertebra. So if it's C3 contact, decompress C3, laterally flex C3, and rotate C3 on C4. Move to the next level, C4, long y-axis distraction, long y-axis and lateral flexion, long y-axis, lateral flexion and rotation, both left and right, in order to regain and maintain full physiological range of motion of each of these cervical facet joints. 2 points. Number one, and I'm leading into some of the federally funded research that we have done, a point about Protocol 1. When you're treating Protocol 1 and you're treating ulnar nerve pain, you'll get more of this in lecture and didactics, but never ever contact the C7 arch and then press your hypothenar contact onto the upper thoracic spine when you're reducing a C7 T1 disc herniation. That is a patient with C8 nerve root or ulnar radiculopathy, because this is actually found to increase intradiscal pressure. When you are treating C7 T1 disc herniation, make the contact, lift, do not press onto the thoracic, do not create extension of this lower cervical spine, only long y-axis decompression to safely drop the intradiscal pressures. Okay. Now, the other way that we treat Protocol 2, and in some cases some doctors like this for Protocol 1 as well, is to use the occipital restraint. When we use the occipital restraint, we will bring the strap over, attach it underneath the headpiece here, and then when we bring this one over, wherever the Velcro crosses, that will be where you're applying cephalid long y-axis decompression. So we lock it under here. Now, we can apply long y-axis decompression using occipital restraint. Via V, I release the long y-axis. If I'm treating a cervical disc herniation, I can contact the arch below a disc herniation when using the occipital restraint. When we were treating before, you'll always contact the arch above the disc herniation when using long y-axis distraction. But in using the occipital restraint, we're going to contact the arch below the disc herniation. Let's say it's a C5, C6. We'll contact the arch of C6, move to the taut point, and apply the 5 4-second pumps, the 20 seconds, which is applied 3 times to a disc herniation, using the occipital restraint. Now, I don't personally use this, but I know some doctors who do. So you can treat Protocol 1 disc herniation with occipital restraint. Just be sure that you contact the arch below the disc herniation. If you get the arch above the disc herniation, you can actually drive the disc hernia into the nerve root and exacerbate the arm pain. In summary, therefore, in treating a radicular upper extremity patient, only use Protocol 1. I prefer the contact and use long y-axis distraction. You can use the occipital restraint, as we've just shown. In Protocol 2 with the occipital restraint, you can also place facet joints through all of their physiological range of motions. Visualize. If I release long y-axis here, and lateral flexion and rotation, I can contact, apply long y-axis, lateral flexion, and rotation to each of the cervical segments. Always begin with long y-axis via V here. Just apply a long y-axis distraction. You okay, Chris? I ask patients that all the time if they're okay. They even say, Doc, you don't have to ask me, I'm fine. But you start with long y-axis, then apply long y-axis with lateral flexion, and then long y-axis with rotation. So if a patient has a rotatory scoliosis of the cervical thoracic spine and say it's to the right side, you can make the contact, apply long y-axis, laterally flex and derotate the scoliotic curve utilizing the occipital restraint. So you can see that as you study the text and visualize this video, you can adapt this technique to any specific patient curvature, pain syndrome, or subluxation pattern. Allow me to ask you a question. Do you ever find that adjusting patients in the upper thoracic can be very challenging? You're familiar with the T4 syndrome. You're familiar that the sympathetic nervous system is heavily innervated here, that its nerves actually pass in front of the ventral ramus. They join spinal nerves. They are sympathetic innervation to nerves that go to the abdomen, the heart, the esophagus. They control autonomic function. They can be extremely painful and tight. They cause neck, shoulder, headaches in patients. People who sit at cathode ray tubes or computers all day long in a flexed position like this, their upper thoracics begin to stand out like buffalo humps. They become very tight, very painful. In my past, it used to be I would try to vector thrust them or use specific dynamic high velocity adjusting, and sometimes nothing would move. It was like hitting a piece of hard rubber, and they would kind of flinch, and I kind of thought maybe I shouldn't have done that. So I don't do that anymore. We treat them utilizing long Y-axis and protocol 2 for these upper thoracic spines. And you all know the case I mean. You see them every day. And they are one of the most challenging things that you and I see as chiropractic manipulating physicians. Try this technique and see what your patient thinks, either with the occipital restraint in place or not. Just begin to apply lateral flexion to the upper thoracics and think about that T4 syndrome. And what causes T4 syndrome? It's posture, it's injury, it's past whiplash injuries. It's postures that change with aging and osteoporotic changes of the spine. And when you begin to mobilize these joints, and you can apply long Y-axis and lateral flexion to the upper thoracics, and you know how tight and resistant and hypomobile they are. And as we begin to apply this technique, they begin to soften and to move. And we do it bilaterally, long Y-axis, lateral flexion and derotation throughout the upper thoracic segments. I tell my patients actually that in my opinion the most important thing I do to them is treat their upper thoracics because of the stress that we all live under, the tightness that we carry in the neck and the shoulders. You see the high blood pressure patient, the heart arrhythmia patient, the stress patient. When you treat these areas, it's very relaxing and very sedating to that patient when we bring back full physiological range of motion. So begin to utilize lateral flexion, long Y-axis with lateral flexion and rotation for the upper thoracic spine. Then lock all of the levers, okay, and with the occipital restraint in place, make your contact. And having put these joints through their physiological range of motion, patients who previously could not be cavitated, and you know this is true because you've tried to cavitate some of these tight upper thoracic spines and they don't move. Here's new technique procedure for treating upper thoracic and cervical thoracic spine. With occipital restraints in place, begin by utilizing long Y-axis distraction. Just contact the spinous processes from C7, T1, move down through the thoracic spine, reach that taut point, the barioelastic resistance, and decompress all the way down to approximately T9, T10. Then apply long Y-axis and lateral flexion And you can do this one of two ways. Either use the thenar and each specific segment, or use thumb contact. Thumb against the spinous process, apply long y-axis, lateral flexion, and rotation to each of these thoracic spines. Now at this time your patient is usually purring. This is very sedating care and very relaxing to the patient. So we will do this on both sides. You can do this without the occipital restraints on as well. Just apply long y-axis, lateral flexion, and rotation in both directions. And as you treat, we begin to feel that we can attain physiological range of motion, which we could not do at the beginning of this application. As soon as we create all of this relaxation in these T4 and upper thoracic syndrome patients, you can then lock the instrument from all movements, and we're going to apply long y-axis distraction as we adjust this thoracic spine. That is, make the usual thenar pisiform contact, and then as you press on the electrical strip applying long y-axis distraction, just make the contact, don't thrust, just hold. And as I treat and do this, you feel that, Chris? You'll feel the cavitations. Actually, doctor, in patients, you'll get more cavitations this way than you will by these forceful, high-velocity thrusts that are commonly used. And you take the patient with degenerative disc disease, facet arthrosis, DISH, scoliosis, even osteoporosis. Don't use the forceful care. Just make the contact, allow the instrument to apply the long y-axis distraction, and as the disc space increases, the facet joints gap, and the intradiscal pressure is decreased, these joints, if they can cavitate, are going to cavitate. This is how we treat upper thoracic and full thoracic spines that just can't tolerate. And remember, with aging, there are more of us who can't tolerate the force of high velocity adjusting, so use long y-axis decompression adjusting for better clinical results. Now I just want to share with you that you do not have to use the occipital restraint. In fact, when you get in a busy day and you don't have time, what you will do is release the lateral flexion and the long y-axis, and you'll apply lateral flexion and decompression by long y-axis application. Thumb contact on the spinous, and just apply lateral flexion to each segment. Then if you see rotation, apply rotation and lateral flexion with long y-axis into this upper thoracic. In a cervical spine, when you see rotation subluxation, as we place joints through full physiological range of motion, because this is such a common thing to my practice, are C2 rotation subluxations. Let's say that C2 is a right posterior rotation subluxation. I'd like to end the cervical spine with this specific example of how you use this instrument to reduce subluxation and regain full physiological range of motion. C2, right posterior rotation. C2 spinous here, laminae, thumb index. Apply long y-axis distraction. And then while under long y-axis, this hand will de-rotate C2. De-rotate, apply long y-axis, and then even apply lateral flexion into the side of that subluxation. So any given pattern of hypomobility or failure of full range of motion can be regained by using the cervical headpiece as we have demonstrated. This is a demonstration of Cox technique. It is not intended to replace the didactic study and the actual hands-on application with certified Cox practitioners. I hope that some of you, or all of you, will find it worthy of your further study and certification in the work. Two textbooks that will help you to reach that point are one called the Neck, Shoulder, and Arm Pain Mechanism, Diagnosis, and Treatment. This is in its third edition, covers the upper extremities and cervical spine. This is Low Back and Leg Pain Mechanism, Diagnosis, and Treatment, published by Lippincott, Williams, and Wilkins in its 7th edition, came out in 2011. All royalties from this book, incidentally, go for research in flexion distraction manipulation. That's what's allowed us to get the federally funding that we now have at Loyola and Hines VA Hospital, the NIH and the HRSA grants to study Cox flexion distraction manipulation. I hope to study with you more in the future.